to start, the Australian Dementia Network acknowledges the traditional custodians of our country throughout Australia and their continuing connection to land, sea, and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures, and to their elders, past, present, and emerging. Just before we launch into the talk, just a couple of things to sort of bring to people's attention. One is the ADNeT registry, which of course you can join by emailing the team. And also there is an option to link your clinic on the ADNeT clinic locator, and you can use that link to register. And I think Valerie's going to be putting these links in real time in the chat for you to click on if you'd like to. Also to bring to your attention the ADNeT neuropsychology norming tool, which is a web-based automated tool that allows you to enter data and receive normative data back out for a range of neuropsychological measures. And there is a link that you can click on. I think Valerie will put that in the chat as well. And then we wanted to talk briefly about CREED, and this is the Centre of Research Excellence in Enhanced Dementia Diagnosis, mainly to mention that the CREED team are running a series of Zoom workshops across Australia over the next 3 or 4 months to learn more about current dementia diagnosis processes, along with barriers and enablers. And they're asking for clinicians and key stakeholders involved in dementia diagnosis to participate. The workshops are for everyone involved in dementia diagnosis, so geriatricians, nurses, neuropsychologists, GPs, allied health professionals, and practice managers and admin staff from memory clinics. And each workshop will go for about 90 minutes with 5 to 10 participants, and participants will receive a $50 gift card for participating in a workshop. Okay, great. Well, I might introduce today's speakers. So we've got Professor Christopher Rowe, who is a nuclear medicine physician and neurologist with 2 decades of experience in dementia research and patient care. He's the Director of Molecular Imaging Research at Austin Health in Melbourne, a professorial fellow at the University of Melbourne, and an NHMRC practitioner fellow. He's the inaugural director of ADNeT. His research focus is, unsurprisingly, the molecular imaging of neurodegenerative disease, particularly Alzheimer's. And he's extensively published with about 350 peer-reviewed publications. The other speaker today is Dr. Jo Robertson. I think Dr. Robertson is going to go first. She's a senior research fellow at Florey Institute at the University of Melbourne. She's a practicing clinical neuropsychologist and has long worked with ABLE and ADNeT research groups, both of whom are leading the way in the development and validation of biofluid imaging and cognitive markers for early diagnosis of Alzheimer's. In this capacity, she also currently coordinates ADNeT's National Screening and Trials program, which has 6 pre-screening sites across the country.
Thanks for the introduction, Edith. I clearly don't need to really introduce myself. You've covered what I do for a job. The only important thing that was left out is that I am also mum to a 5-year-old border collie who you can see in the photo there named Raggles. So for today's presentation, I'm going to race through reasonably quickly. I think the slides are relatively self-explanatory, and I'm happy for those to be circulated to give us maximal time for Chris to talk about the amyloid PET results, because by far they're the most frequent questions we get from clinicians about, looking for guidance on what to do with that information. So I am going to cover the cognitive and mood measures that we use in our ADNeT pre-screening program. I will describe them and the way that they are interpreted. I'm also going to provide some suggestions about the way that you might disseminate this information to your patients, and very briefly talk about what happens to all of the data that we collect. So by way of background, the ADNeT Screening and Trials program is one of ADNeT's 3 key initiatives. Its main aim is to recruit and pre-screen subjects who are interested in participating in further research and trials. Patients who are symptomatic come to us typically by their specialist clinicians, whereas asymptomatic patients can refer themselves via our online portal. The aims primarily of ADNeT Screening and Trials initiative is to expedite trial completion via accelerating recruitment to trials. It means that patients and clinicians have access to cutting-edge diagnostics that they can't otherwise access at no cost. And it means that ADNeT researchers and collaborators are funded to collect research data that we wish to have. And so the idea is that expediting trials attracts pharmaceutical companies, trials and money to Australia that wouldn't otherwise come here, and maximises the access of Australians to these promising trials. So the core neuropsychological battery that we do as part of the ADNeT screening program is listed here. It comprises an ADNeT PAC, which is a composite measure, CDR, GDS and GAI. Now, I will cover what those abbreviations mean in subsequent slides. And the battery that we do as the core battery is chosen heavily based on what most big pharmaceutical trials use, so that we can be pre-screening people accurately to assess their subsequent eligibility for trials. Now, today, in the interests of time, I'm only going to run through the particular measures that we feed back to specialist clinicians who refer their patients to us, but which are these ones that are highlighted now in green. We do a whole lot more neuropsychological testing on a large subset of our patients. I've listed them here for your information, but I won't be covering these today. So this slide just gives you a screenshot of the template results letter that we send out to clinicians once their patients have undergone ADNeT screening. So many of you who have referred patients will be familiar with this, and this is how I've broken down the measures that I'm going to talk about next. So the mini-mental state examination, the MMSE, is a very, very common cognitive screening measure. It splits 30 items into domains, but the domains or the profile are not particularly meaningful pieces of information. Basically, the total number of correct items is what's meaningful about this screening measure. So scores range from 0 to 30, with lower scores indicating worse performance. And in terms of interpretation notes, scores of 27 to 30 are considered normal. Scores of 21 to 26 are suggestive of mild mild impairment. So this would correspond typically to a patient with MCI or mild dementia. Scores of 20 to 25 are suggestive of moderate impairment, and scores under 20 are suggestive of severe impairment. Now, the MMSE as a clinical instrument is fairly sensitive, but it's not specific. So if people have scores that are reduced on the mini-mental, then usually something is going on. It's not entirely clear typically what it is. Logical memory is the next measure that I will cover. It is a subtest of the Wechsler Adult Intelligence Scale. Logical memory is a paragraph-length story that we read to participants who then must recall as many details as they can. So they need to recall the story immediately after it's read to them, and then again after a 30-minute delay. And they are scored 0 to 25 based on the number of components of the story that they correctly recall. In terms of making sense of how they're going, scoring-wise, their score out of 25 can be converted to an age-adjusted standard score using normative tables that are provided in the WACE-4 manual. However, our administration and many clinical trial administrations of this subtest are not to the manual specifications. It prescribes that you read the story twice and you also read another shorter story. We read the story once. And so we and other trial protocols often stipulate their own cutoff for cognitive normality as an inclusion criterion for the trial. So broadly speaking, most of the preclinical trials that adopt this measure require that a person is able to recall 8 or more pieces of information after a delay for that to be normal performance. The next measure I'm going to talk about is the CDR, or the Clinical Dementia Rating Scale. It's a scale that was specifically designed to assess severity of impairment due to Alzheimer's disease. It's a semi-structured interview of a patient and an informant, and it takes around 45 minutes to administer in total. There's also a comprehensive training program that qualifies you to rate the CDR, and that takes about 9 hours to become accredited. And as a trained rater, on the basis of the semi-structured interview, you assign scores indicating severity of impairment due to cognitive loss across 6 domains, which are listed here. The CDR output is that you get a global score, which is a weighted average, and you also get a CDR sum of boxes, which, as it sounds, is the sum of all of the box scores you assign to each domain. The global score is the most commonly used index from the CDR, and a global score of 0 indicates that the person is not demented. A score of 0.5 equates to questionable dementia, or in practice, most frequently patients who score 0.5 on the CDR at the MCI stage clinically, and a score of 1 or higher indicates that the person is demented. The GDS, the Geriatric Depression Scale, is a screening instrument for depression in the elderly population. It was designed to help distinguish pseudo-dementia from dementia, and it was specifically designed for elderly people and therefore less focused on somatic symptoms, which you may see in non-depressed elderly patients and could be mistaken for depressive symptoms. So it's argued to be of use in populations of elderly persons who might be physically ill or cognitively impaired. The original scale included 30 items, which subsequently has been revised down and validated for a 15-item brief version. So you can see in the little screenshot that I've put, there's 15 items that are answered with a dichotomous yes or no. And the interpretation of this scale is that if a person scores between 0 and 10, they're not depressed, and if they score 11 or higher, they're possibly depressed. Next measure is the Geriatric Anxiety Inventory. That's a self-report scale of 20 dichotomous items that canvasses anxiety symptoms over the past week. It's again designed to be specifically applicable to an elderly population and limits the inclusion of somatic items. It scored 0 to 20, with higher scores indicative of greater anxiety symptomatology. Interpretation guidelines for the GAI are that somebody scoring between 0 and 10 is considered to be of normal, and somebody that scores 11 or higher is consistent with a DSM diagnosis of generalized anxiety disorder. And this scale was designed in the first instance to discriminate patients that met DSM criteria for generalized anxiety disorder from those who did not. So that's my rocket through the different measures that we send you results about. Hopefully that was clear enough, or if not, you can read back through my slides. One of the questions that I do often get from referring clinicians is how they canvass this information with patients, what to say to patients. And obviously, I don't want to tell any of you how to suck eggs. You're all experienced clinicians. But I think it's important to say that what you say to people depends on their clinical status. The level of detail and bottom line differs for people who are cognitively intact versus cognitively impaired. I think that it also depends on the person's biomarker status. So if somebody's amyloid negative, the implications of poor performance on cognitive measures are perhaps of less concern to them. I think that it's important to tailor what you say depending on eligibility for further research and trials. And so people who are found to be eligible on cognitive grounds for onward referral to a drug trial are probably less preoccupied with their logical memory score than somebody who has been ruled out of participation based on that score, for example. I think also that what we say to patients about their scores on these cognitive screening measures needn't be exquisitely detailed. It can often suffice to say that this is a brief screening battery that's especially designed based on clinical trial requirements. And the reality is we're ticking boxes to assess their suitability. It can be helpful, especially if you're talking to patients who have failed an inclusion criterion for a trial, to sympathize with them. The trials are really strict about who they will let in, and they're looking for people that have a score on these measures within a very narrow range, so they can control their trial protocol. Finally, I think it's worth noting that you could consider elevated mood scale scores as triggers for further assessment and intervention if these things haven't been picked up as part of their clinical workup for the patient. They're obviously not sufficient in and of themselves, but they can flag that additional information might be useful there. The other thing that often it's worth talking to patients about are modifiable risk factors, and this figure from a semi-recent Lancet Commission review about the number of cases of dementia that might be modifiable is sometimes useful. We think that probably most of these factors modify the rate of disease progression rather than the pathology itself, but still it's never too late to do things like improve your cardiovascular health or treat physical issues that can be treated, even if the mechanisms are sometimes unclear. As a neuropsychologist, I often get asked by patients about brain training and should they do brain training. It's a controversial area, but in the field of neurodegeneration, my bottom line is that if you do a whole lot of Sudoku puzzles or a whole lot of crossword puzzles, or you spend a whole lot of time sitting in front of your computer doing an expensive brain training program, you'll get very good at those tasks, but probably not much better at remembering what to buy at the grocery store. So I wouldn't be suggesting that people do these kinds of things, flog themselves to do these kinds of things in preference to going out for a walk in the sunshine, meeting their friends and having a coffee and a nice conversation. And finally, we're often asked what happens to all of the data that we collect. It's retained indefinitely. It contributes to our extensive repository of cross-sectional data that we've been collecting for a very long time. Subjects who are not enrolled in a trial are invited to come back at 2 yearly intervals if we have the funding to collect that data, to give us serial assessments and longitudinal data on them. The data is available for interrogation by our internal researchers and also external collaborators. There's a link there if you would like to apply to access that data. And a subset of the data is provided to commercial partners who contribute the funding to our program to assist trial recruitment. On this slide, I've got some additional resources that might be useful for you. I've got my contact details. Please contact me if you have any questions at all. I'm more than happy to answer them or to talk about any of the measures that we administer in more detail. And that's it for me. Thanks for your time.
Okay, so I'm talking about amyloid PET. I'm going to give you a bit of background to it. I'm going to give you a bit of a tutorial on how to read amyloid PET. And we're going to talk about the significance of amyloid PET findings. So what are the benefits of an amyloid PET? They do improve diagnostic accuracy, particularly for Alzheimer's disease versus frontotemporal dementia. They do allow earlier diagnosis of Alzheimer's disease in the MCI phase, something we refer to as prodromal Alzheimer's disease. The classical clinical criteria for Alzheimer's disease don't permit you to make the diagnosis until the patient has dementia, which can be quite frustrating for patients and clinicians alike, and can obviously delay access to appropriate treatments. Amyloid PET can identify preclinical people in the preclinical early developmental phases of Alzheimer's disease before they have significant symptoms. They can actually pick up the accumulation of amyloid plaques for 15 or more years before they reach the typical level found in Alzheimer's disease dementia. Amyloid PET has improved subject selection for therapeutic trials. There's plenty of evidence that 30% of people given a diagnosis of Alzheimer's disease don't actually have it. We know this from post-mortem studies, but this has now been repeatedly proven by amyloid PET, when screening people referred for Alzheimer's disease trials, the negative rate is about 30%. And amyloid PET measures the effectiveness of anti-A beta drugs, and that's become particularly important in recent monoclonal antibody trials against amyloid. There are appropriate use criteria for amyloid PET because it has been approved in the United States by the FDA for clinical use. However, it hasn't been funded, and being the United States, it's particularly expensive. If you go to Stanford or University of California, San Francisco and say, I'd like to have an amyloid PET, they'll say, fine, but you have to pay $16,000 US out of pocket. If you go to Harvard or other hospitals in Boston, they'll say, yes, you can have amyloid PET. It'll cost you $3,500 out of pocket. So it's worth making the trip across the United States if you do want to get an amyloid PET from one side to the other to save money. Anyway, the bottom line from all this is that it's too expensive and hasn't been widely used because we haven't had effective disease-modifying therapies. So why spend that huge out-of-pocket amount of money? That could be all about to change, of course, with the positive phase 3 lecanemab trials. For this reason, various pharmaceutical companies are now investigating reimbursement, and in Australia, they're investigating TGA registration and then Medicare reimbursement for amyloid PET in anticipation of it being a requirement for getting access to anti-amyloid therapy. So back, if we consider we don't have a therapy, these were the criteria that were derived by the Alzheimer's Association and Society of Nuclear Medicine Task Force. And they felt that the cost of amyloid PET, well, not exactly the cost, but a reasonable cost for an amyloid PET would be justified for investigating early onset dementia, so people less than the age of 65. At this time, the clinical features of Alzheimer's disease are often atypical. There's often a marked behavioural component, and differential diagnosis with FTD can be quite difficult. In patients with MCI, 50% are developing Alzheimer's disease, 10% other dementias, but 40% don't go on to develop dementia. So an amyloid PET at this stage can really help you sort out the diagnosis and prognosis of your patient. And then dementia of uncertain cause after expert assessment. So the proposal was that you shouldn't do amyloid PET in a typical AD case with age of onset in their mid-70s, for example, and typical progression on history. You shouldn't do it in asymptomatic patients, and you shouldn't do it in patients that don't have objective cognitive abnormalities on testing. But as I've mentioned, some of this could be changing somewhat because of what will be a new indication, which is confirming suitability for anti-amyloid monoclonal therapies. So let's have a look at amyloid PET. So 3 traces have been approved by the FDA and the European Medicines Association, agency actually. That's florbetaben, florbetapir, and flutometamol. Each company has described how it likes their scans read. And of course, they all have to be different. So the first one that came out was florbetapir, and they said, we want our scans read in black on a white background. Florbetaben then came out and said, we want our scans read in white on a black background. The reality is these scans look almost identical if you change the background. And my preference actually is a white background with a black scan. And that's how I read these agents. Flutometamol is a bit different. This is the GE product. It has higher white matter binding, but it's also got higher binding to amyloid plaques. So they actually recommend a color scale. And a color scale is what we have always used for PIB PET, and we also use it in Australia for our NAV4694 PET scans. So this is what you're looking for. Amyloid negative on the left, amyloid positive on the right. These are florbetapir scans. So a negative result has been shown at post-mortem to correlate with no amyloid plaques and have a very high negative predictive value for Alzheimer's disease pathology. Scan on the right is abnormal, and at post-mortem you will find moderate to frequent neuritic plaques, and this is a strong indicator of Alzheimer's disease and certainly increases the likelihood of Alzheimer's disease being the reason for the patient's clinical decline. So how do you read these? Well, this is a floor beta band scan, white on black, but the same rules apply to all the scans, no matter which tracer you're using, because no matter which tracer you're using, the amyloid's always in the same place. So what you like to see in a negative scan is a clear gap between the hemispheres up until you start cutting down into the corpus callosum. Now, there is white matter binding in all these traces. So once you hit the corpus callosum, you'll see the hemispheres joining up. But above that, there should be a clear gap. This person doesn't have a clear gap. If you look on the far left top corner, it's touching at the parietal cortex there towards the back of the slice. The next one down, there's a lot of touching or kissing, which seems to be the term that gets used in teaching programs for this kissing of the hemispheres. This means there's binding of tracer in the cortex, not just the white matter. So you're actually seeing the hemispheres close together. You then go further down and you're seeing activity going right out to the edge of the brain in all these slices. You'll see later on that in a negative scan, or as I showed earlier, we'll just go back to that. Here in a negative scan, you're seeing what's described as a tree in winter approach, and on the right, a tree in summer approach. So you've got the branches on the left, but on the right, you've also got the leaves, which are out in the cortex. So these finger-like extensions of white matter, you're looking in a negative scan, you see these finger-like extensions of white matter going out towards the edge of the brain. In a positive scan, you've lost that white matter pattern and the brain looks fairly smooth right out to the edge. Okay, so if you look in the transaxial slices on a negative scan, you should see the corpus callosum, but you shouldn't see activity in grey matter adjacent to that. So here we have some negative findings. You can see the corpus callosum, both on a floor beta bend scan on the left and a floor beta per scan on the right. You don't get binding of tracer in Alzheimer's disease in the cerebellar cortex. So if you look in the cerebellum, you can see the normal non-specific white matter binding, and all these traces are a bit sticky, so they tend to bind to the myelin of white matter. So you can see that there's white matter there in the region of the cerebellum, but around that, there's no activity. So this cerebellar grey matter is what negative grey matter should look like. So you can help use that to make a judgment when you're looking higher up in the brain. And because if you look up into the hemispheres, you're seeing that the activity is going right out to the edge and there's no areas apart from a few very large sulci, but the cortical areas are all showing uptake of tracer. So that can be used as a bit of a normalization or standard setting region. When we use a color scale, we use a rainbow color scale. Now these do vary from manufacturer to manufacturer. This is the one we particularly like to use. You need to set the white matter of the cerebellum to just a bit below maximum. So in this color scale, red is the maximum. So we crank up the color scale until we just see a few bits of red appearing in the cerebellar white matter. So the one on the left, the intensity is set correctly, as you'll see by the arrow. There's a hint of red appearing in the cerebellum. The one on the right is too low. There's insufficient blush of red, and that could you could undercall the amount of amyloid present. So this is what we like to see. Here's 3 examples. There's a negative scan on the left. We're just seeing white matter in this color scale. There's a bit of venous blood pool activity right at the back there, so don't confuse that with grey matter. There's a moderately positive scan in the middle of the page. You can see there's no gap between the hemispheres, and there's clear binding in that medial parietal precuneus posterior cingulate area, as well as out in the lateral parietal cortex and in the frontal lobes. There is relative sparing of the sensory motor cortex between the parietal and the frontal lobes. And this is a characteristic feature of Alzheimer's disease. It doesn't affect primary cortex. So the visual cortex should be normal in the occipital lobe, medial occipital regions, and the sensory motor cortex should be normal. On the right, we have a strongly positive amyloid scan. So this is a typical clearly positive NAV scan. There's binding in the frontal lobes. We go up to the top left hand, there's frontal binding. There's that gap due to sparing of the sensory motor cortex. There's parietal binding. As we go down, we can see that not only the lateral parietal, but also the precuneus, which is the medial parietal region, and further down the posterior cingulate to some extent. The occipital cortex, and once we get down to the third row, is relatively spared. We also see binding in that third row in the anterior striatum. So it's part of the basal ganglia. It's mainly the caudate nucleus. We go further down, we can see still a lot of frontal. We see lateral temporal binding. We don't see medial temporal binding. And in fact, neuropathology studies show that the density of plaques in frontal cortex is 4 times higher than in the hippocampus in patients with Alzheimer's disease. So though we've been traditionally fixated on the medial temporal regions in the hippocampus because of MRI findings in that region, it's actually not an area of much amyloid plaque deposition. And then right down in the last few slices, you can see that cerebellar white matter, but no binding in the surrounding cerebellar grey matter. And you can confirm that the intensity of this colour scale has been set correctly because you're just seeing those little bits of red in the cerebellar white matter. And this is a negative NAV4694 scan. A good separation of the hemispheres, apart from a little bit of sagittal sinus blood pool activity, giving that little dot there. Then as you slice down, you see them coming together because of the corpus callosum joining the hemispheres. But all the way throughout, you're just seeing these finger-like projections with no activity out around the brain. So it's a clearly negative study. These are some techniques that have been suggested by others to help you read an amyloid scan. We'll skip the top one. So I'm not sure actually what they're talking about by the temporal ridge, but again, there's the kissing of the hemispheres, this time down at the lower end of the brain. But in the next one, there's this gap in the frontal areas, which they refer to as a diamond. Then the finger-like projections, they refer to as a cartoon hand. This is in the negative study. On the right, you can see that gap between the hemispheres closed up and some kissing between the hemispheres. If you look on the coronal slice, you've got the tree in winter in the negative study, and the tree in summer for the positive study. If you're looking up in the parietal slices, you can see there's almost a double convex lens gap between the white matter. But once you have amyloid, the hemispheres come together and you lose that gap. Then there's something you can sometimes see on the sagittal, and there should be a gap between where the where the orbitofrontal cortex white matter ends and where the brainstem thalamic activity is, because there's filling in of the anterior striatum, so it makes a continuous bridge there. I don't use that much myself. I think that's a bit of a subtle sign, and you're better to look on the transaxial slices directly at the anterior striatum area. Now, there is a standard method of quantifying the amount of amyloid on an amyloid PET scan. It's called the centiloid method. So basically, there's a standard region of interest applied to an individual brain after that individual brain has been put into standard anatomical space. So it has to be warped and stretched a bit to make it into a standard shape. So you put that region on, you get one big region measuring the amount of activity in the cortex that you find amyloid in. and you divide it by the activity in the cerebellum. That gives you something called an SUVR ratio. You then apply that to an equation that gives you a result from 0, which is what you find in young negative amyloid negative people, and 100 centiloids, which is the mean that's been applied to the typical scans you find in mild Alzheimer's disease. So it's like a Celsius scale from 0 to 100. Instead of for temperature, it's the amount of amyloid in the brain, and it works very nicely. In fact, it's been quantified against post-mortem. Less than 12 centiloids equates to no amyloid plaque. Greater than 25 centiloids is associated with significant amounts of amyloid compared to what's called the CIRAD classification. So this is moderate to frequent plaques. Greater than 50 centiloids correlates reasonably well with having the neuropathological criteria for Alzheimer's disease. So these are the ways, this is the criteria that pathologists use to classify whether somebody's got Alzheimer's disease or not. It takes in not only the amyloid plaques and the density, but also the distribution of neurofibrillary tangles. So you don't see much tau in a brain until you get to 50 or more centiloids of brain. So this correlates quite well. You build up your amyloid, you then develop the plaques, and you later develop the cognitive impairment of Alzheimer's disease. So we use a threshold of 25 to define a positive scan, but a threshold of 50 is best if you're trying to support a diagnosis of clinical AD. Now, there are factors that affect prognosis in an Alzheimer positive, in a amyloid PET positive person. So you can have people that are perfectly normal with a brain full of amyloid. Now, that's for now. If you follow these people, you do actually detect declining in cognition. If you have amyloid in the brain and it's above 50, it's also likely that you'd have a positive tau PET scan. If you have both of those, then your prognosis is relatively bad in that you have at least a 50% chance of developing mild cognitive impairment within 4 years. If you're amyloid positive but tau negative, that risk is much lower. And if you have less than 50 centiloids of amyloid, that risk of progressing from cognitively normal to mild cognitive impairment is actually much lower. Again, I'll actually show you the graphs for this. So the level of amyloid in the brain does determine the prognosis, particularly in cognitively unimpaired people, so in normal people. Once you get into the dementia phase, the level of amyloid, as long as it's above 50, doesn't tend to have much effect on diagnosis or prognosis, because by that time, tau has taken over and is the main driver of cognitive decline. Your level of cognitive performance when you have your amyloid PET scan, again, this mainly refers to so-called cognitively unimpaired. But if you have got, say, minus 0.8 standard deviation memory performance in a positive amyloid scan, that's bad news. It means you're moving towards, you're closer to getting to that MCI phase. If you have small hippocampal volumes, that's bad news. If you have co-existent cerebrovascular disease, well, the effects of the pathologies of Alzheimer's disease and cerebrovascular disease are additive on your risk of developing dementia. So that's another factor that changes your prognosis. If you have a lot of cognitive reserve, and this is basically measured by years of education, then you seem to be able to tolerate amyloid in your brain for longer before you develop cognitive impairment. Certain genetics, being an ApoE4 carrier and a brain-derived neurotrophic factor metalleel carrier, seems to be associated with some faster decline, although it may also mean that you've had the disease longer, because being an E4 carrier, you actually start accumulating amyloid plaques at an earlier age, at least 10 years earlier than people that don't carry this allele. Then lifestyle factors may affect prognosis. Generally, we say that exercise is good, smoking is bad. You must get your blood pressure treated fairly aggressively. And diet is, your diet should be sensible. And if you've got diabetes, it's probably may worsen your cognition. Whether these factors come into play once you're already showing cognitive decline is questionable. Most of these lifestyle factors are retrospective and based on what you did in midlife, and by the time you get symptoms, it's not clear really that changing these factors alters your prognosis. But we tend to offer it to patients because we don't have much else to offer them. So amyloid accumulates slowly, and this is a publication we put out back in 2013 based on longitudinal data from the ABLE study. It shows that amyloid's accumulating for about 30 years before you get to the amount that you get in typical Alzheimer's disease, and we can pick it up on a PET scan about 20 years beforehand. So this is prognosis versus amyloid level. So this is your survival meaning what your percentage chance over time is of not having developed the disease. So if you're a normal person and you have an orange or red amount of amyloid in your brain, which is more than 50 centiloids, you can see that by about 5 years, well, if you've got 50 to 100, your 5-year risk of developing MCI, it's not too bad. It's about 25%. But by 7.5 years, it's 50%. If you've got over 100 centiloids, then your 5-year risk is about 50%. On the other hand, if you've got less than 50, then by 5 years, you're still normal. If you already have MCI, then your risk of progression to dementia, it also relates to how much amyloid you've got in your brain. Basically, if you've got more than 50 centiloids, then within 2 years, you've got a 50% chance of having dementia. And in 4 years, you've got a 75% chance of having progressed to dementia. Now, I'm going to show you some scans. We're going to read them together, but this is the report I give out. So this is the standard template. Now, I do love reading amyloid scans because they're actually quite easy and the reports are very fast. So we do a standard acquisition with NAV 4694 from 50 to 70 minutes post-injection of 200 megabecquerels. And then the report either reads, there is normal non-specific uptake in white matter. There is no uptake of tracer in grey matter. Conclusion, the scan is negative for amyloid plaques. This makes Alzheimer's disease very unlikely. So I leave that and delete the second part. However, if it's the other way around, I delete the first part and then it's left with findings. There is binding of tracer in cortical areas, and then I select either mild, moderate, or high degree. So delete the two that aren't appropriate. Areas involved include the frontal, precuneus, posterior cingulate, lateral parietal, lateral temporis, and the striatum. It's usually all those areas, but sometimes you need to delete some. Conclusion, the scan is mildly, moderately, or strongly positive for amyloid plaques. So I have to delete the two. So it's just a matter of a bit of deletion, and I've done my report. Now, my reports also come out with these very important interpretation notes. So mild to me means there's a little bit of something there, but gee, it's going to be less than 50 centiloids. It's not really going to be enough to explain cognitive impairment in a symptomatic person. Something else is going on. So a moderate or high binding of amyloid supports a diagnosis of Alzheimer's disease in someone with dementia, or prodromal Alzheimer's disease in someone with mild cognitive impairment. So moderate or strongly positive in MCI or dementia, I say they've got Alzheimer's disease. In MCI with definite memory impairment on psychometric testing and a positive scan, dementia usually develops within 3 to 5 years, so a bit of prognostic information. Low levels of amyloid plaques can be detected 15 years before dementia, so may be an incidental finding. So if I give a mild, what I'm saying is that this could be an incidental. The frequency of finding amyloid plaques goes up exponentially with age in the normal population. It's 10% in normal people aged in their 60s, but it's over 50% of people aged in their 80s. So if somebody's presented in their 80s with dementia and you find a bit of amyloid plaque, I don't think it means much. It may be making a little contribution to their cognitive impairment, but there's probably other disease processes that are more relevant. Or they might have severe depression. My notes also say the sensitivity of PET for detecting amyloid plaques sufficient to meet neuropathological criteria for AD is 90 to 95%. And that's been proven in large post-mortem correlation studies. Then, amyloid positive dementias include Alzheimer's disease and about 50% of patients with dementia with Lewy bodies. Pure cerebral amyloid angiopathy usually produces only a mildly or perhaps moderately positive scan, tends to look a bit more patchy than your typical Alzheimer's disease, but we can't really tell the difference between cerebral amyloid angiopathy and Alzheimer's disease. And of course, most patients with Alzheimer's disease have a degree of cerebral amyloid angiopathy. However, amyloid is relatively specific for Alzheimer's disease. And when it's present in Lewy bodies, it means they've actually got not only Lewy bodies and alpha-synuclein, but they've got AD-type pathology as well. Now, amyloid negative dementias are interesting. I do get feedback from time to time. Look, this patient of mine has got hippocampal atrophy on MRI, a classic progressive amnestic cognitive decline. They're a cut and dry Alzheimer's disease, but you're telling me their amyloid scan is negative. I think you're wrong. Then I say to them, how old is your patient? And they'll say 83. And I'll say, well, what they've got is late. So hippocampal sclerosis, as it used to be called, is now referred to as late. Limbic predominant age-related TDP43 encephalopathy. It's actually found in 40% of postmortem brains as the dominant pathology causing dementia in people over the age of 80. So because we're now getting these negative studies, we're changing the diagnosis from Alzheimer's disease in quite a few patients to late. FDG PET can help with late. It shows really severe medial temporal hypometabolism, but relatively mild changes elsewhere in the brain, as opposed to Alzheimer's disease, where the predominant areas of hypometabolism are in the temporoparietal cortex, with relatively mild, in fact, even normal findings in the medial temporal regions. Other causes of an amyloid negative dementia include those 50% of DLBs, but then frontotemporal dementia, this rare thing called tangled dominant dementia, but that's really quite rare. Progressive supranuclear palsy, corticobasal degeneration, Parkinson's disease dementia, and vascular dementia. So I give the clinician these explanatory notes to help them put the report into clinical context. So what we're going to do now, until you get sick of me, is look at scans. I'll give you a couple of seconds to make a diagnosis. You have to decide whether they're normal, mild, moderately, or highly or strongly positive, because that's going to influence how you put this into context. As I've said, a little bit of amyloid, don't get too excited. It's probably incidental, but if it's moderate to highly positive, then it's very likely that Alzheimer's disease is a major contributor to the cognitive impairment. Remembering that in older patients, postmortems usually show multiple pathologies contributing to dementia. So in this one, I hope you've made up your mind. My opinion is that it's a completely negative scan, and their centiloid score was actually -5. You can see there's a good gap between the hemispheres. There's no real smoothing out of the cortex. Nothing's kissing. There's no caudate nucleus anterior striatum lighting up. So negative scan. Have a look at this one. I'll give you 10 seconds to decide what this one is. No, I'll only give you 5 seconds because it's so glaringly obvious. And fortunately, most amyloid scans fall into these two categories as clearly negative or clearly positive. And this one is strongly positive or highly positive. And you can see there's red in the frontal cortex, the parieto-temporal cortex. The anterior striatum is lighting up, the lateral temporal lobes are lighting up. You've got the typical sparing in sensory motor areas and in visio and in medial, relative sparing in medial occipital cortex. So, and the Centiloid score on this person was 125. This one, give you 5 seconds on this one, another pretty clear. It's negative, Centiloid score is 1. Yeah, it's purely a white matter pattern. This one, what would you call it, mild, moderately, or strongly positive? Time's up. This is a high positive. It's not as highly positive as the others. The Centiloid score, though, was 95, consistent with a strongly or a highly positive scan. So no doubt that if this person is presented with cognitive impairment, they have got significant Alzheimer's pathology contributing to their presentation. This one's chosen because it's a poor quality scan. And it's poor quality because you've got blood pool activity. So for some reason, there's been some breakdown of tracer, and it's still, and the activity is still floating around in the bloodstream instead of all being cleared. So hence the sagittal sinus there in the top left at the back of the brain there is quite bright. And as you go down, you can also see in the second and third image from the right on the second row, there's activity not only, there's in both the inferior and superior sagittal sinuses, I think they're called that. Then as you go further down, you've got the transverse sinuses in that last image on the right in the third row at the back of the brain. That's all blood pool activity in the venous sinuses. And then going down into the neck and the face, you can see all this blood pool activity. But despite that, you can still read the scan. It's still clearly negative. And the Centiloid score was -5. This one, bit of a look, give you 10 seconds. It's negative with a Centiloid score of 8. The brain looks a little bit perhaps more full than those really classically negative ones, probably because this is a slightly younger patient. They've got more white matter and less atrophic brain. So don't go by the size of the apparent size of the brain. Look for the fingers going out to the cortex and the separation of the hemispheres. This one, you get 2 seconds for this one. So highly positive. Actually looks higher than what the Centiloid says. Sometimes the Centiloid's not quite in keeping with visual, and it may be there's a bit of activity in cerebellar grey matter that's just altered that ratio measurement. So drag the Centiloid score down a bit. But that'll do. So I hope you've got an idea of not only how to read amyloid scans, they're pretty straightforward once you get the hang of it, particularly using a good tracer like NAV, and that you know how to now put it into clinical context. I will stop sharing.
Got a question about the sensitivity and specificity of neuropsychology assessment for neurocognitive disorders versus structural and functional imaging. Was it a head-to-head question? Either of you?
Well, we certainly know in terms of the sensitivity and specificity of neuropsychological testing that I think, as Chris mentioned, for clinical diagnosis of Alzheimer's disease based on cognitive testing is often wrong. But I'm not certain that structural and functional imaging other than amyloid or tau PET are phenomenally better. But Chris is best to comment on that aspect.
Yeah, so structural imaging is really the main benefit of structural imaging is to work out what the vascular contribution to cognitive impairment is. Hippocampal atrophy is a bit subjective. You have to rate it depending on whether somebody's above or below the age of 75, and then it's not disease specific. As I've pointed out, the most severe hippocampal atrophy occurs in late, not Alzheimer's disease. And in young onset, early onset Alzheimer's disease, you don't get hippocampal atrophy, you get parietal atrophy if you see anything. So MRI, we always have a look. In my clinic, we always rate the hippocampal volumes, but it's not terribly specific.
I think many of us that work in biomarker research agree that it will soon be indefensible not to incorporate biomarker evidence into diagnostic algorithms. Do you agree with that, Chris?
Once they become more affordable and more accessible. The blood biomarkers are actually very promising, and I think they'll hit the market within a year or two. And I suspect it'll be routine clinical practice to take a blood test to support a diagnosis before long of Alzheimer's disease.
Yeah, I'd agree with that. I've got a couple of linked questions which I'll try and sort of put together. The question is about, in the slides that you talked about, the presence or absence of cognitive impairment in addition to amyloid positivity being a predictor of what the trajectory would be. So somebody's asked what the definition of cognitive impairment is in that situation. Is it bedside screening testing or clinical neuropsychology or both?
Well, these cohorts have all been done in research settings, and so they've used pretty strict definitions of mild cognitive impairment. Anything less than mild cognitive impairment gets called cognitively unimpaired, and the definitions are usually at least -1 to -1.5 standard deviations reduction in one or more cognitive domains, but memory being the outstanding one.
So they're not thinking about screening measures in this instance. They're talking about normed neuropsychological tests.
Yeah, that would be consistent with what we're doing with ADNeT and within Shiva's studies as well.
Yep. And I haven't mentioned subjective cognitive impairment.
Yes, yeah.
So basically, subjective cognitive impairment is incredibly non-specific because everybody gets worried about their memory over the age of 60. And in fact, it correlates more strongly with anxiety scores and obsessional personality traits than it does with neuropathology. So we don't find any increase in amyloid positivity associated in people with subjective cognitive impairment. There are some degrees of subjective cognitive, if people around them are saying, hey, your memory's slipping, then that's a bit more than just, I'm worried about my memory. So in those cases, you might be at increased risk, but generally don't put too much weight on subjective cognitive impairment.
Thank you, Chris. And there's a question about the difference in the advantages relatively of amyloid versus PIB-PET.
Versus PIB?
Yeah.
Well, PIB is amyloid PET. The problem is, PIB was the first tracer, but it's carbon-11 based, which means you have to make every single dose. You have to run the cyclotron, and the radiochemists have to make every single dose because it only lasts for 20 minutes.
Yeah.
So that has been replaced by the F18 labeled tracers, which have a half-life of 2 hours. And if you make enough, you can make it last the day and do 20 subjects, 20 participants from one production.
Yeah, so the short answer is really it's about half-life, which you sort of point out. And I might just take one more. We've got somebody that's asked about what level of amyloid load might direct you starting a cholinesterase inhibitor. It's a tricky question. I don't think an amyloid load would answer the question, but
no, you've got to make the diagnosis of Alzheimer's disease. Now, as I've said, over 50 centiloids or a moderate or strongly positive, or moderate or highly positive amyloid scan certainly strongly supports a diagnosis of Alzheimer's disease in someone with objective cognitive impairment. So in that way, it can help you confirm your diagnosis of prodromal AD or Alzheimer's disease dementia. Of course, in Australia, we're restricted by PBS rules to not giving acetylcholinesterase inhibitors to MCI. You're supposed to wait till patients have dementia and significant reduction in their many mental state score. It's not the case in the United States, where 50% of people with MCI are on an acetylcholinesterase inhibitor. There isn't convincing clinical trial evidence of benefit, but then there haven't been many trials done in MCI because these compounds have been around so long, they don't have major pharma support anymore, so nobody's done big trials in them for decades.
Yeah. I'm just trying to scroll through the Q&A just to see. Any precautions and adverse effects prior to an amyloid PET scan?
No, you don't have to prepare in any way. There's no fasting required. There are no immediate side effects. There is radiation exposure. It is a typical nuclear medicine study. That radiation exposure is about 5 millisieverts, which is about 2 years worth of what we normally get just living in our everyday environment. So that's similar to other diagnostic radiology procedures like a CT scan of your chest or a bone scan. The risk of that is very theoretical. There's no direct evidence of cancer induction below 50 millisieverts, and we're talking about 5 millisieverts. But if you're being very conservative, you can draw a straight line down from high dose exposure to zero exposure and do a calculation, and it comes out that theoretically this could give you about a 1 in 1,000 lifetime risk of developing cancer.
Thank you. I think there aren't many more, and there's a bunch of comments, but I might just moderate those and we'll move on. And thank you both for your time. I'm just mindful that we're about 5:06. I haven't got an opportunity to share slides, but there will be a survey link that pops up after this webinar, so please feel free to answer the survey. And the next webinar will be in December, and you'll all receive information about that. But I wanted to take this time to thank you both. Thanks, Chris. Thank you, Joe, for taking the time to present. Really appreciate it. Thank you.